Hello, Dr. Sohail.
Hello, sir. Can you hear me?
Yeah, you're audible.
Let me just see whether I can share my screen. If you could give me the screen sharing right.
Good evening, Dr. Sahel. I'm Shrikant from AstraZeneca, diagnostic
Good evening,
medicine.
sir. Let me just see how I would share my slide.
Good evening, Divya ma'am. You're on mute, ma'am.
Yeah, hi.
Yeah, ma'am.
Good evening.
Hello,
Good evening.
everyone.
Yeah.
Hello, everyone.
So, is my slide visible now to all of you?
No, sir, your slides are not visible.
I just shared my desktop. Oh, I forgot that.
Something now it is coming up. Yeah,
Is it now being shared? Is it visible now?
now it's fine, sir. Now it's fine.
Great, wonderful.
Thank you.
So, just a preliminary question. Who all are the target audience for this particular discourse today?
It's predominantly pathologist, sir.
All right. So, I think we still have a couple of minutes before the actual official starting time. So, let me know when you're good to go.
So, Anita, on a countdown
Uh,
of
so,
five, can we start?
yes, sir. So, on the count of five, we are initiating today's webinar. So, yes, yeah. Very good evening, everyone, and thank you for attending this webinar today. Let me invite Dr. Vivek Gupta for setting the context and take the event forward. Over to you, Dr. Vivek, sir.
Thank you, Anita. Very good evening to all of you. On behalf of Molecular Pathology Association of India, I welcome all the esteemed faculty members and delegates for attending this educational event virtually. And let me take a moment to proudly say that MPI has successfully organized a series of educational webinars on our different topics. And this is the sixth webinar of this year, 2025. And the healthcare system, as we know, are moving from the singular approach to the personalized healthcare. And this topic is very much relevant, like HER2 in pan tumors is for the precision oncology. Human epidermal growth factor receptor 2 or HER2 is a protein which is involved in the cell growth and division, and in some of the solid tumors it is abnormally expressed in high amounts that can lead to the cancer and grow that the cells grow more rapidly and cancer can spread. So HER2 testing is very important and is now increasingly recognized as an essential step in precision oncology, extending beyond the breast cancers and the gastric cancers to include other malignancies such as endometrial, lung, colorectal, and ovarian cancers. So it is very important for us to determine the HER2 status in these patients, and it is very critical for identifying these patients for the newer HER2 targeted drug therapies. So through this webinar, let's understand and learn what are the new updates on HER2 testing, and beyond that HER2 testing in that breast and gastric cancer, and how the HER2 positive testing in solid cancers are managed in the era of new ADCs, which is antibody drug conjugates, such as n 2 which is the combination trastuzumab and and Druxican, which offers a high cytotoxic payload to the cancer cell. And to start this meeting, let me invite Dr. Sohail Qureshi, who will be educating us on the HER2 positive, HER2 pan tumor, biomarker utility, and ADC therapeutics. Dr. Sohail is an additional director and unit head in medical oncology and in the Fortis Hospital at New Delhi. Over to you, Dr. Sohail.
Thank you, Dr. Vivek, for that wonderful introduction to set the ball rolling. I believe my slides are visible. Are they? My screen visible to all of you?
I think you need to put the sharing on, Dr. Sohail.
Okay, I'll have to go back to the talk and start but I started sharing it once already. Is it visible now, sir?
No, maybe you can stop and reshare it again.
Because it was when I started sharing it earlier. Just a moment, it will be visible now. Is it there now, sir?
Yeah, perfect.
Great. So let's get started. And this is going to be an interesting session. And thank you, Dr. Vivek and AstraZeneca for bringing up this wonderful opportunity for a new learning. And I believe that just as the new drug TDXT and HER2 is at the forefront of breaking new frontiers with bringing a completely different paradigm shift in the management of HER2 positive cancers across the board. Similarly, such initiatives will go a long way in not just educating the medical fraternity, but also making this drug available to a wide variety of our patients for their better treatment and overall better health. So what I'm going to be discussing today is the importance of HER2 testing and the role of anti-HER2 new drugs in pan tumors and the utility of the biomarker and antibody drug conjugate therapeutics in this particular domain. So this is what is already known to us, that HER2 as a clinical entity expression is prevalent across a wide range of solid tumors. And we all know that that a HER2 new positive subtype of a cancer usually portends an aggressive phenotype of that disease. We all have great experience of treating HER2 new in the breast cancer domain. But now we are beginning to realize a greater utility of testing for HER2 new across different tumor types, not just limited to the breast. The need right now is to start understanding the importance of routinely testing HER2 new in different solid tumor types, and also to understand what standardized criteria exist for the reporting of HER2 new across different tumor types, which at the present moment are not uniform or standardized to any particular criteria, except for the fact that in gastric cancers, where the TOGA trial had actually given a completely different set of criteria for reporting of HER2 new in gastric and esophageogastric adenocarcinomas. And even in that trial, there was a difference in reporting for small biopsy samples as well as on the larger histopathological surgical specimen. So it is not the same as reporting HER2 new in a breast cancer vis-a-vis reporting HER2 new in a core biopsy or endoscopic biopsy from a stomach adenocarcinoma, or a surgical specimen of a gastrectomy where you would see HER2 new expression. But what is uniformly understood is that in patients who have HER2 expressing solid tumors, where there are no approved HER2 targeted therapies, it becomes very difficult to treat these patients when the current lines of treatment are exhausted. And therefore, it becomes all the more important to test these patients for HER2/neu, because this can become a new ray of hope for these patients, as we shall see in the subsequent slides. Okay, so HER2/neu expression, as I was talking, is quite frequent across different metastatic solid tumor types. Breast carcinoma, which is the poster child for HER2/neu expression, you would perhaps see that breast would have around 20% patients who would be 3 plus on IHC. Another 40 to 50% of patients will be 2 plus or equivocal on IHC. And these would eventually have around 25% of these patients would eventually have a positive FISH as a companion diagnostic. And some of these patients would also have around 5% of patients would have a HER2/neu mutation on genetics and next generation sequencing. But the important thing to be realized is, look at where biliary tract is actually going. Very neck and neck with breast. So HER2/neu 3 plus is almost 10% of biliary tract cancers. And if you were to include the HER2 2 plus, that would mean 25%. So effectively, 1 out of every 4 patients of biliary tract cancers would have a HER2/neu 2 plus. And if you were to combine them with HER2/neu 3 plus, then that would eventually translate into around 35% patients of biliary tract cancers expressing HER2/neu and becoming potential candidates for anti-HER2/neu treatment after having exhausted their current lines of treatment armamentarium. Add to that another 5 to 7% of patients who would have an HER2/neu amplification based on FISH, and another 10% with HER2/neu mutations. That consumes almost 50% of biliary tract cancers who become candidates for anti-HER2/neu therapy. So this is extremely important. Another organ that I would like to draw your attention to, third from the bottom, is endometrium, wherein HER2/neu 3 plus is seen in approximately 25 to 30% of patients. If you add the HER2/neu 2 plus to them, then another 30% get added. So effectively, around 50 to 60% of patients with endometrial carcinoma would also eventually have some degree of HER2/neu expression, which would make them potential targets for HER2/neu targeted treatment. Bladder carcinoma, another of those organs where HER2/neu testing is taking rapid strides. And after the advent of antibody drug conjugates like enfortumab vedotin, it is now the turn of anti-HER2/neu antibody drug conjugates to make their foray into this particular field. And if you would see the bladder cancer expression, then almost 65% of patients will have some degree of HER2 expression, either 2 plus or 3 plus, and they would also become candidates for anti-HER2/neu treatment at some point of time in their treatment journey. So these are the NCCN recommendations on HER2/neu testing across different tumor types, along with the different treatment options, although they are not uniform, and the guidelines do not talk about which line you would want to test them and exactly at what point in time during the journey would antibody drug conjugate based on HER2 will become will the patients become candidates for. But for now, a slightly clearer picture is starting to emerge with some cancers. For example, in NSCLC, for patients who have advanced metastatic non-squamous NSCLC, who have already exhausted the first line treatment, then there is definitely an indication for doing NGS testing for detection of HER2/neu mutations. And if these patients are able to be detected for HER2/neu activating mutations, then they become candidates for trastuzumab deruxtecan-based therapy. Similarly, for colorectal and biliary tract cancers, if these are metastatic or unresectable, as well as for endometrial carcinoma, for all high-grade histologies like serous carcinomas or carcinosarcomas, or those who harbor P53 mutations, these are the patients that should be tested for HER2/neu expression regardless of histology. And in some of these cancers like endometrium, now anti-HER2/neu therapy is making foray in the first line along with paclitaxel and carboplatin. So there's a lot of noise these days about the advent of immunotherapy in endometrial carcinoma realm, with trials like Ruby, which is for dostarlimab, or pembrolizumab with the NGOT trial, and the trial Duo-E for durvalumab. But let us not forget that even in these trials, the patients who tested positive for HER2/neu were advised to take HER2/neu treatment upfront rather than immunotherapy. So let us not get too much enamored by the wonderful responses to immune checkpoint inhibitors, and let us not forget that testing HER2/neu is important in these gynecological malignancies. And if one is able to find a HER2/neu expression, then these patients will be well served to be treated first with a trastuzumab-based approach along with chemotherapy rather than immunotherapy. So these are some other guideline recommendations from different societies like ASCO and ESMO regarding gynecological malignancies and genitourinary, which is bladder. So in bladder cancer, HER2 is not routinely recommended, and it's not the standard practice even as far as ESMO is concerned. And therefore, the targeted therapies are not a part of standard treatment for bladder cancer. However, it may be remembered that bladder cancer domain is expanding rapidly with the advent of FGFR mutations, and now even HER2/neu is beginning to make its entry into the bladder cancer domain. As far as endometrial carcinoma is concerned, I've already outlined that in patients with serous histology or high-grade features or P53 mutations, these patients should be tested with IHC, and if IHC is equivocal, then an associated FISH must be done. And if these patients are detected to have HER2/neu positivity, then the recommendation for them is to add trastuzumab-based treatment along with chemotherapy for these patients. For cervical cancer, although there are not the HER2/neu testing is not routinely recommended as a standard practice because of low prevalence of HER2/neu in cervix cancer, but in uncommon histologies like adenocarcinomas, this should be considered, and therefore there is a case in point for testing for HER2/neu in uncommon histologies in cervical cancer, not so much in squamous. As we all know, expectedly, squamous cell carcinoma, HER2/neu expression is rather rare. Then for ovarian cancer, ASCO and ESMO both do not routinely recommend testing because of low HER2 prevalence. But as we shall see in the slide later, that ovarian cancer is also beginning to go the HER2/neu way in a certain subset of patients after having exhausted most of the lines of treatment. So with that background, we now come to this particular trial, Destiny Pan-Tumor02, in which TDXT was given for all HER2 expressing solid tumors, and it was a phase 2 open label multi-center study which enrolled all patients of advanced solid tumors who are not eligible for any curative therapy and were second line or beyond in their treatment journey of their particular tumor type, and in which HER2 expression was either 3+ by IHC or 2+. The cervical cohort was expanded to include 5 patients who are also IHC 1+. Prior HER2/neu targeting therapy was allowed in this trial, and patients had to have a performance status of 0 to 1. The gastric scoring, which I was alluding to earlier, the TOGA trial-based parameters were used to determine the IHC status in the gastric cohort. And this trial actually had a TDXD dose of 5.4 milligram per kilogram of body weight every 3 weekly, and roughly 40 patients were included for every cohort that the trial was intended to include. The primary endpoint was confirmed objective response rate by the investigator-initiated assessment, and the secondary endpoints included the duration of response, the disease control rate, the progression-free survival, and overall survival, as well as safety signals that might arise thereof. So this is, at a glance, the objective responses and the duration of responses that were seen across the board from different tumors. And you would see a staggering 84% response rate for IHC 3+ in the endometrial carcinoma domain. And for IHC 2+ in the endometrial carcinoma, this was 47%. Remember, all these patients were second line or beyond. That means they were extensively treated by at least 2 lines of therapy before these patients were taken up for HER2/neu based treatment. Cervical carcinoma, IHC 3+ patients, 75% objective responses and 40% for IHC 2+. The median duration of response in endometrial carcinoma not yet reached. In cervical carcinoma, 14 months. Ovarian carcinoma, this is the primary treatment where HER2 is not yet making a case in point, but now here IHC 3+, 63% patients had an objective response if they were IHC 3+, with a median duration of response of almost 1 year. And this was observed across the tumor type, except for the rare pancreatic primary, wherein these robust responses were not really seen. So these are the curves for the efficacy endpoint for progression-free survival, which was the secondary endpoint of this study. And you could see that for all cohorts, the orange line on the top left curve, IHC 3+, 11.9 months. So that's 1 year, almost PFS of 1 year in the intention to treat all cohorts. The cervical cancer cohort, the IHC 3+, PFS not yet reached. Endometrial cancer, the one on the top right, for IHC 3+, again, PFS not yet reached. And for ovarian cancer, 12.5 months of PFS for the patients who are IHC 3+. Even the patients who are IHC 2+ are not doing too badly either across different gynecological cancers here. The same PFS curve for the other primary tumors. So in bladder cancer, actually it is neck and neck, and therefore not much of a difference between IHC 3+ or 2+, 7.5 months of PFS. For biliary tract cancers, again, for IHC 3+, PFS of around 7.5 months. For other tumors, overall, the IHC 3+ patients had a median PFS of 23 months. That's like 2 years from the time of diagnosis. So that is something which is really phenomenal and extremely welcoming to see on first glance. The PFS and OS curve by HER2 status. So if you would see the curve on your right, the all cohort overall survival Kaplan-Meier estimates for IHC 3+ show 21 months of overall survival in this heavily pretreated population across different tumor types who have different disease biologies, different exposure to perhaps chemotherapeutic agents, maybe hormonal agents, maybe radiation therapy, and therefore this would constitute a group of patients who have been exposed to a wide variety of drugs. And for them, 21 months is a phenomenally good figure, which is almost nearing 2 years. For IHC 2+ also, this overall survival was almost 1 year, which is 12.2 months. So these are similar curves across individual tumor types. Safety summary, so no new safety signals. We know that TDXD has different profile when it comes to adverse drug reactions, and for drug-related treatment emergent adverse events were of grade 3 or more were observed in around 40% of the patients. Out of these, serious drug-related adverse events were observed in around 13% of the patients. For 8% of the patients, these drug-related adverse events necessitated dose discontinuation, whereas for 20% of the patients, only dose interruptions were warranted. So reasonably well-tolerated drug. The important side effect of interstitial lung disease or pneumonitis, which was adjudicated as specifically related to TDXD, was observed in only about 5 to 6% of patients if it was grade 2, and only 0.4% of the patients for grade 3. So not much of a threatening signal of ILD noticed over there, which is one of our main concerns for patients who are taking TDXD. In my own practice, I make it a habit to repeat an HRCT of the chest to rule out interstitial lung disease every 8 to 10 weeks when the patient is on this particular drug. And the longest I have had a patient on TDXD was for a lung indication, and that patient had actually taken it for about 16 months before the patient eventually progressed. So other side effects, most commonly, which are seen in more than 10% of the patients, are your usual suspects: nausea in around 55% of patients, fatigue, neutropenia, an important Side effect, around 1 in 5 patients will have grade 3 or more neutropenia, and that needs to be taken care of, especially in patients who have been heavily pretreated with chemotherapeutic drugs and would have a reduced marrow reserve. So what does this lead us to? So the robust response rates and survival outcomes in this particular Destiny Pan-Tumor02 study are encouraging, and they were observed across different tumor types in heavily pretreated patients. TDXT demonstrated clinically meaningful activity across a panoramic spectrum of HER2 expressing solid tumors. The overall response rate, objective response rate was around 37% in all patients and 61% in patients who had an IHC of 3+. These responses were durable, and the median duration of response was almost 1 year in all patients and closing to 2 years in those patients who had IHC of 3+. And these durable responses meant meaningful progression-free and overall survival, not only in all patients. So the PFS was roughly 7 months in all patients and 1 year in patients who were IHC 3+. And the overall survival was actually more than a year in all patients and nearing 1.5 to 2 years, 21 months in those patients who were IHC 3+, with no new safety signals which were consistent with the known adverse event profile of TDXT. And therefore, this particular trial, the Destiny Pan-Tumor02, supports the potential role of TDXT as a tumor-agnostic therapy for patients who express HER2 across different solid tumor types. That brings me to the next important study, which is Destiny Lung02. This was actually a dose-blinded, randomized, multi-center, non-comparative phase 2 trial. So important thing to realize is that these patients were the study of the patients in this study were not powered to be statistically compared between the treatment arms, and basically it was a dose escalation study wherein patients with metastatic HER2 mutated non-small cell lung carcinoma who had received 1 or more prior anti-cancer therapy, so that means they were second line or beyond, including platinum-based chemotherapy were enrolled. These patients had to have a measurable disease as per RECIST 1.1 and a performance status of 0 or 1, and they were stratified as per prior anti-PD-L1 treatment or not, if these patients had received anti-PD-L1 treatment previously or not. The randomization was 2:1 between 2 different dosage arms. The first one was the standard 5.4 milligram per kilogram of body weight every 3 weekly, roughly 100 patients. And the other one was an escalated dose of 6.4 milligram per kilogram of body weight every 3 weekly, and that included around 50 patients. The primary endpoint again was confirmed overall response rate by blinded independent central review. And the secondary endpoints were investigator-assessed confirmed ORR, the duration of response, the disease control rate, PFS, as well as overall survival and safety signals. So this was, in a nutshell, the summary of the efficacy outcomes. The overall response rate was nearly 50% in the lower group, the lower dose, which was 5.4 milligrams, the standard dose, and in the escalated dose, it was around 56%. The disease control rate was also roughly equal between the two, 92% in the higher dose, 6.4, and 93% in the standard 5.4 milligram per kilogram dose. The duration of response was also similar, 12.6 versus 12.2 months between the two treatment arms. And the follow-up was also similar, 16 to 16.5 months between the two groups. So this forest plot of the subgroup analysis of the lower dose or the standard TDXT dose of 5.4 milligram per kilogram body weight showed that it really did not matter whether the patient had been previously exposed to anti-PD-L1 treatment or not. And the responses in the arm were observed regardless of the number of prior systemic therapies the patient had received, and even the presence or absence of CNS metastasis. Similar story for the higher dose also, that this was consistent with regardless of the number of prior systemic anti-cancer therapies, and the patients were responding regardless of the CNS metastasis or not. So the PFS curves are actually neck and neck, and they're actually going together for both these doses. And if we were to see the median PFS for both these doses, then for the higher dose 6.4, it was around 13 months. And for the standard 5.4 dose, it was around 10 months. But then I should reiterate that this trial was not intended as a comparison for these two doses. Overall survival also going neck and neck between both these two doses, 17.3 months and 19 months in the lower dose respectively. So what did this trial actually tell us? So the median treatment duration was similar, around 7.7 to 8 months. The rates of drug-related treatment emergent adverse events associated with discontinuation, reduction, and interruption of this particular drug were lower in the standard 5.4 milligram per kilogram arm, and this was consistent with the primary analysis. The most common adverse events observed in the grade 3 or more severity were GI or hematologic in terms of nausea, neutropenia, fatigue, and poor appetite. So what did this trial conclude? So finally, in this analysis, we were able to show that both these doses, 5.4 and 6.4 milligram per kilogram, continued to show durable and strong responses in patients who were previously treated with in HER2 mutation metastatic NSCLC, and these responses were observed regardless of the number of prior systemic therapies or baseline CNS metastasis, and the safety profiles were acceptable. No new safety signals were observed. The quality of life was maintained throughout the duration of the treatment for which the patients were on TDXT, and no detrimental impact on quality of life was ascertained. And overall, the approved dose of 5.4 milligram was associated with a favorable risk-benefit profile and a reduced incidence of drug-related pneumonitis, drug-related emergent adverse events, and also the more important interstitial lung disease, because you're talking about patients who already have lung carcinoma. So that reinforces the use of TDXT in this patient population. Finally, a brief analysis of the Destiny CRC02 subset. So this was a randomized, blinded, two-stage, two-arm, multi-center phase 2 study in which the stage 1 was randomized between, again, these two arms, and the stage 2 was non-randomized, in which the standard 5.4 milligram per kilogram body weight dose had enrolled an additional 42 patients after the first stage. These patients were HER2 positive who were either pan-RAS wild or mutant, BRAF wild, unresectable, recurrent, or metastatic colorectal carcinoma. The primary endpoint was again objective response rate by blinded independent central review. So if you were to see the two columns on the right, that is the sky blue and the light blue columns, then you would see that the overall response rate across these two dosages were pretty similar. The 6.4 milligram dose had around 28%, whereas the response rate in the 5.4 milligram was around 38%. The confirmed disease control rate, again, very similar, 86% in the 5.4 milligram dose and 85% in the 6.4. Other parameters, the depth of response, the median follow-up were also relatively similar across both these two different arms. So again, just to wind up my talk, what are the key messages that I'm seeing? Sorry. So HER2 expression is prevalent in a range of solid tumors and associated with a biologically aggressive tumor phenotype. Therefore, a poor prognosis and an increased risk of disease recurrence. The PanTumor02 evaluated the efficacy and safety of this particular drug in patients across the board for different solid tumors who are expressing HER2 in some degree or the other. This excluded those primaries wherein the role of HER2 therapies is already established, mainly breast, gastric, lung, and colorectal. And in these pan-tumor subsets, anti-HER2 therapy demonstrated clinically meaningful activity even in the heavily pretreated population. In Destiny Lung 02, the approved dose, which is a standard 5.4 milligram per kilogram, was associated with a favorable risk-benefit ratio and a reduced incidence of adverse events. The safety of TDXT was consistent across the trials, across different treatment indications, and no new safety signals were observed. The biomarker data supports the need for a validated clinical diagnostic test and a consistent algorithm across different tumor types outside of breast and gastric carcinoma, which can be used for identification of these patients who are HER2 expressing, who are HER2 positive, to do away with the heterogeneity, to train our pathologists for this particular testing so that more and more patients can become candidates of anti-HER2 therapy and be benefited by the same. And given the encouraging anti-tumor activity and the durable responses, further research is warranted to better define exactly which patients with HER2 mutations may derive greatest benefit from TDXT. Thank you very much.
Thank you, Dr. Sohail. That was indeed very interesting to know about the different tumors that are being taken up into the HER2 positive and the different trials that they are taken up and their responses to the new ADCs. It's very interesting to know, and it has expanded the horizon of thinking that the different tumors that have to be taken for the different trials, HER2 targeted trials for ADC. Thank you. Just an announcement for the audience, like whatever questions they have, they can put it into the Q&A box. We will take it as in the end of this session, we will take all the Q&As. So now let's move on to the next session, which will be the agenda for the next part. Now, I'll invite Dr. Jay Mehta for to moderate a panel discussion on HER2 in pan tumor driving precision therapy with novel ADCs. Dr. Jay is an oncopathologist and president head of Newburgh Oncopathology Center at Mumbai. And along with this, may I request the other panel members to join Dr. Sohail Qureshi, Dr. Sindhura, Dr. Divya Mida, Dr. Sushila, to join as panelists and take the discussion forward. Can I have the introduction slide for all the respected panel members?
Yes, sir. Just a second.
Yeah. Yeah, Dr. Sindhura is senior consultant medical oncology, hemato-oncology, and bone marrow transplant, Star Hospital at Hyderabad. And and Dr. Divya Mida is a senior consultant pathologist at Tata Memorial Center in Kolkata. Our area of interest include gynecology, gynec pathology, uropathology, soft tissue pathology, and she has made a significant contribution to this field. Yeah, welcome, Dr. Divya. And then Dr. Sushila, who is a senior consultant pathologist and HOD pathology in Indo-American Hospital and Research Center, Hyderabad. She has 49 publications and a lot of significant scientific projects in this reputed institute, and with 24 years of experience in oncopathology. Yeah, over to you, Dr. Jay.
Very warm welcome to everyone who's attending and my fellow panelists. And they've already been introduced. So from the medical oncology side, we'll be having Dr. Suhail and Dr. Sindhura, and my pathology colleagues, Dr. Susila and Dr. Divya, will be tackling the pathology part of this process. So we saw this slide, HER2 expression is prevalent in a wide range of solid tumors. And the thing you notice here is that there's really a wide range in those numbers as well, depending on the tumor site. And that's precisely the reason that we are going to address this question in this meeting. And it's to do with the fact that all of these solid tumor types lack a standardized criteria for evaluation. So say, for example, here the range of endometrial ranges from 4% to 28%. That's a very wide range. And it's to do with the fact that different criteria have been used to actually evaluate HER2 in these tumors. So to begin with, to our medical oncology colleagues, so what's your current practice and experience in terms of HER2 testing and management for solid tumors other than breast and gastric cancer? So can I request Dr. Suhail to take that query, please?
Yes, sir. Can you hear me?
We can hear you. That's correct. Yeah.
Yeah. So I think now, apart from breast and gastric, we are beginning to test HER2 across different tumor subtypes, especially endometrium, for all biliary tract cancers. for patients who have exhausted any previous lines of therapy and do not have any meaningful chemotherapy available, any option available with them, especially in endometrium. Patients who have high-grade serous histology, carcinoma, sarcoma, who are P53 mutated, these are the patients who would have a greater propensity of getting HER2 positivity across the board. Apart from that, once patients have exhausted therapy like immune checkpoint inhibitors and platinum-based chemotherapy in lung, then because in metastatic lung, we also order upfront NGS for detecting these mutations. And many of these patients who actually turn up with a HER2 activating mutation are the patients who would perhaps be candidates for anti-HER2 targeting. Apart from that, I was just reading yesterday that some rare tumor types, like even sarcomas, who have different kind of expressions of either immune checkpoint or HER2. So these are the patients who might be potential targets in the future for testing for HER2, because these are the patients who have very limited therapeutic options available from once they have exhausted 1 or 2 lines of chemotherapy.
That's very interesting. So from what I hear, I'm just wanting to re-emphasize endometrium and biliary tract are the other potential candidates where you're likely to get some HER2 expression. Dr. Sindhura,
Correct.
what's your real-world experience for HER2 positivity rate in the above tumors, the non-breast and the gastric cancers?
I would say roughly around 10 to 15% of biliary tract and close to 20% of endometrial are positive. So routinely we are testing for biliary tract, endometrial and colorectal. But frankly speaking, have not been routinely testing in the other malignancies like the ovarian, cervical, bladder, pancreatic. So around 10 to 15% is what I would say.
Okay, so that's the good thing. So again, to highlight here, so something ranging between 10 to 15% you would expect to get, particularly endometrial cancers, which are P53 mutated and of the serous subtype, where they are more enriched in getting the HER2 positivity. So that's what we need to keep in mind. Dr. Suhail very elegantly discussed this slide, so I won't spend much time on this, but again, the fact remains that the ranges are very wide, and that's to do with the different criteria having been used to establish the HER2 positivity in these tumors. Also to remember that some of these tumors also have HER2 mutations, such as in the biliary tract cancers, and a very small proportion of lung cancers also have HER2 point mutations or exon 20 insertions. So this is to my pathology colleagues across these Destiny pan-tumor trials, the colorectal trials, the lung Destiny lung trials. They surprisingly use the DARCO Hercept test for testing HER2 in a variety of solid tumors. But in real life, most of the laboratories in India tend to use the Ventana platform, or some of them even use the manual platform. So would this potentially affect identification of HER2 IHC3 patients? Dr. Sushila, you want to take this query?
One and all, I think I'm audible.
Yes, you're audible now.
Yeah. So this is regarding the thing. Even in our lab, we are using Ventana platform only, which is very commonly used. It is an automated platform, but the testing varies. We do only in the gastric and breast, not in other tumors. So what is the experience we face means presentation will be little different from the Ventana platform. We used to the same platform, then we are comfortable in reporting. So HER2 3+, we don't feel any difficulty in identifying, but 2+ and 1+, little difficult, because sometimes the 2+ faintly stained by DACO, and which we consider as 1+. So that is the difficulty we face. Mainly we get these slides for second opinion or for the equas and all that. During that time, we face the difficulties. So in case the block is available, we retest using the Ventana platform and confirm with the reports.
Okay, so that's very interesting. So the point here is that if you do it by the DARCO testing, it's slightly less intense, the intensity of the staining versus the Ventana thing. And as Dr. Pichila said, you would probably want to retest something on the Ventana platform, because that's something that everyone is used to looking at. Dr. Divya, how would you view the role of an EQUAS program since we're talking of this variations in intensities, would it benefit for labs to participate in EQUAS programs to kind of just to circumnavigate this problem?
Good evening, everyone. Thanks, Chair, for your question. I think EQUAS is going to have a huge role. We are in a country where people are using a whole lot of different methods. Somebody is using a manual method, someone's using another platform. So EQUAS is very, very important. And I think the most important thing will be that the EQUAS should be designed in such a way that to ensure that the differences are not due to methodology itself. And they should provide, because now we need to test 0, 1 plus, 2 plus more accurately, they should be able to, give us samples across for testing, like all sorts of all tumor tissue types they should give us for testing when we are enrolling for an EQUAS program. And they should test not only the staining quality, they should also test the interpretation. I feel that's also very important. So it should be testing for both for staining and for interpretation. And the case selection should, as I said, should represent the whole range of HER2 expression, positive, negative, borderline, cases with some tumor heterogeneity. They should send us all for testing. And both staining quality and interpretation. And of course, there should be a feedback by us. And they should also give us a feedback highlighting what are the key areas where people are making mistakes. Is it the process? Is it the platform? Is it the antibody? And then leading to, consensus. So I think this is how the EQUAS enrolling in an EQUAS program will help us.
That's very nicely summed up by
I would
Dr.
like to
Divya.
add. I would like to add a point with Dr. Divya. I think the pre-analytical issues also should be addressed. So if they advise us to process the tissue, what is processed in our lab, to send it across and let them check whether it is properly processed or not. That also will help us.
Absolutely, ma'am. Absolutely.
So to sum up, what we are talking here is that both analytic and post-analytic parts needs to be kind of, part of the EQUAS process, and a bidirectional communication between the EQUAS provider and the participant is necessary to understand where one is going wrong, or, if you're right, then it's good enough. But if something's off, then you need to understand why. So that's a great thing. And it's very interesting, we use the labs will use a lot of different antibodies for HER2 testing. Very interestingly, despite the fact that these DESTINY trials use the HERCEPT kit for HER2 analysis, a lot of studies have actually shown that the Ventana clone 4B5 is the most accurate IHC method for assessing HER2 expression in gastric cancers vis-a-vis the other antibodies. The good part is that most of the labs are using the 4B5, so that should prevent this issue from assessment of HER2 testing. And this is to both our colleagues here in all of these DESTINY trials. Again, as I said, not various, but they use the HERCEPT DACO test for testing it. But they use the gastric-specific HER2 scoring guidelines. But some of the laboratories use the FADER trial criteria, for example, for endometrial cancers, and the Heracles trial criteria for colorectal cancers even now. In the opinion of my colleagues here, which scoring criteria should be used to score HER2 in solid tumors beyond breast cancer, particularly when the intent is to treat with TDXT? So let me put it to my pathology colleagues as first question. Now, any one of you can answer that.
Yeah. For treating, for the other cancers apart from breast, it is better to use gastric criteria for the other solid tumors, because the tumors are very heterogeneous, and many a times we don't get the complete circumferential staining and all that. So in such cases, the patient will get deprived of the treatment if we call it as negative. So it is better to use the gastric criteria for all other solid tumors, though it is not properly mentioned in the guidelines. It is better to use the gastric criteria, and whenever we get any request for any other solid tumors, we use the gastric criteria. If it is an in total hysterectomy or ovary specimen and all that, we use the large specimen criteria. If it is a true cut biopsy or anything, we use the gastric biopsy criteria.
Okay, so are you not using the FADA trial criteria or the Hercules
No, because
trial
that is
criteria?
some 30%, 50%, all the, in
Okay.
FADR criteria, it is 30% lateral and that is considering the gastric staining pattern only, but it needs 30% of cells positivity. That is very difficult to get it. So we use only the ASCO guidelines gastric criteria only.
Okay, so this is good to emphasize to the audiences that we should be using the gastric tumor evaluation criteria for the non-breast cancers, if possible. At least if that should be used. To our medical oncology
So
colleagues,
one question, sir. One question, sir. If I may ask my pathology colleagues, which I've always
please.
wondered that in the TOGA trial, there were different criteria for the core biopsy and the histopathological specimen. So are we really finding that the histopathological specimen is perhaps the important specimen where this has a greater meaning, or the core biopsy is equally predictive of response to anti-HER2 therapy?
So
Would you
we'll
rather
come
have it
to
done?
it in the subsequent slides. In the biopsy, we use just cancer cell clusters, which are just about a whole cluster of 5 cells versus 10% of the overall population for the resection specimen to account and cover for the heterogeneity. So either one can be used depending on what specimen that you have. Okay, and to my treating colleagues now, do the scoring criteria matter depending on the HER2-directed therapy? Say if you had a trastuzumab-based monotherapy versus using TDXD, would you want different scoring provided to you? Dr. Sindhura, do you want to answer that?
Yeah, so basically, as I think we go by the testing criteria, what the trials have actually incorporated. So this is what we generally follow, because again, individual patient decisions would not be based upon the testing alone. It's primarily based upon the trial designs. So as Dr. Sushila madam had already pointed out, it is better to give the chance to a lot number of patients. That is the reason why gastric pattern of staining is what we look into. And but majority of the times what I observe is the reports of HER2 do not actually mention which type of criteria is used to report it. That's one major problem that we face. But I think the criteria, whatever has been used in the trial, for example, if it is a pan HER2 pan tumor, then it should be a gastric type reporting, and that's what we look at.
And one more thing, the question is scoring criteria change according to the therapy. Because if you are planning for trastuzumab and pertuzumab, it is only positive or negative.
Yes.
And here the positive, if it is 3+, frank positive. If it is 2+ with ish positive, then we call it as positive. If 2+ and ish negative, then we call it as negative. 1+ negative, 0 is negative. So we have only 2 criteria in cases of in our institute, we follow like that. HER2 directed therapy, if it is towards trastuzumab and pertuzumab, it is only 2, positive or negative. But if the patient is, if the clinician is planned for DXD, then they will ask divide the negative also. So in such cases, we call it as 2+ ish negative and 1+ that is low and 0 ultra low and null, total null. So we divide into then 4+1, 4+2, 6 criteria, 6 categories.
So sounds good. So that's if you have a trastuzumab or pertuzumab monotherapy, then it's basically a binary answer. You want a yes or no situation. And if it's the DDXT, then you would also like to know about the HER2 low and the HER2 ultra low status. So that's the additional information that one has to provide if depending on the therapy to be used. So there's a difference between the scoring for breast cancers and for gastric cancers. Essentially, the difference is in the point that while for breast cancer, circularity, that's a complete membrane staining, is sacrosanct. That's not so the case with gastric or G-junction tumors, where you can have the basal staining, the lateral staining, basolateral staining, or only the lateral staining. As far as the extent goes for biopsies, they are interpreted for a cluster of even 5 cells. And the cutoff for resection specimens is 10% of the entire population, which is the same for breast cancer. But unlike breast cancers, gastric cancers are actually of the gland-forming intestinal type, and therefore they may demonstrate incomplete basolateral or lateral staining. And if we therefore applied the breast cancer criteria to gastric cancer analysis, you would miss a whole bunch of gastric tumors and you would incorrectly call them as HER2 negative. And from this is where the TOGA trial came up with the idea that you would have had this smaller proportion of cells in a biopsy and 10% of the entire population in a resection specimen, so as to mitigate the risk of not missing out a false negative HER2 staining result. This is a more elegant pictorial way of showing this. This is what is the complete membrane staining versus the basolateral and only lateral staining. Remember that this is the breast and it's about 10% of the entire population. Likewise, for the gastric criteria here, again, 10% of the population, this is resection surgical specimen and clusters of 5 cells in a biopsy specimen. Now, the gastric scoring criteria have been applied to most of the other solid tumor types, particularly the destiny pan tumor. And this would include the colorectal, ovarian, cervical, endometrial, and non-small cell lung cancers. The bottom line being the HER2 expression is rather heterogeneous amongst all of these tumors. And why were these criteria applied? For the precise same thing that I just said, it's because of the heterogeneity of staining in these tumors. The only kind of drawback was that they used the HERCEP testing for this and not the Ventana 4B5, which all of us currently use. So the considerations when one chooses a scoring system is that to bring some uniformity into the system so that the same message goes across to our treating colleagues when they read the HER2 reports, and how can they actually implement them and action the report. So as we discussed, we have the FIDE trial criteria for uterine serous carcinoma, which requires huge, more than 30% of the tumor cells to be positive, and the Heracles is even more unprecedented. 50% of the cells need to be positive. These are just difficult to get. Unless you have a big resection specimen, it would be almost impossible to get this, and you would just end up calling everything as HER2 negative for these endometrial tumors or colorectal cancers. And this is a more recent kind of update given by the CAP for the carcinomas of gynec origin to remove all these confusions about using the different trial criteria. And the recommendation now is similar to the gastric criteria. So you have all the same one, negative score 0 to negative positive score 3+. And that's based on the biopsy and the resection specimen criteria for gastric cancer. So this is the endometrial thing. And for the surgical specimens, again, more than or equal to 10%. But you can have either complete membrane, basolateral, or lateral staining, likewise for the specimens. But there again, you consider only a cluster of 5 cells. So essentially, what you're doing is applying the gastric criteria for all gynec cancers for the latest CAP update for gynec cancer HER2 evaluations. And given the potential need for rescoring the HER2 expression depending on the clinical indication, the percentage of tumor cells with strong complete or basolateral or lateral membrane staining should be reported in the report, in addition to the overall HER2 IHC. So what they're saying is just don't call it score 2, actually write down what it actually entails. So what is the percentage or how many cancer cell clusters you have done? Because tomorrow there's something else may come up, and it will be just easy to refer back to this description in your report. So to my pathology colleagues, do you face any sampling issues while performing HER2 testing? Essentially to focus on the tumor quantity or the ideal number of biopsy bits, something to do with tumor heterogeneity, or does it matter if the tissue was decalcified and you had a bone biopsy of a metastatic lesion? Dr. Divya, would you want to address these issues?
With regard to HER2 testing, say in, let's say, breast cancer, the most common one, it's not sometimes only the quantity, it's the quality of the invasive tumor cells. So I would be happy if I had maybe 2 to 3 cores of good tissue having enough invasive tumor cells, but I can confidently call it, I can confidently do HER2 testing on. So for breast, I don't think there is some problems like that. Sometimes when they ask us to do HER2 testing on cell blocks, which have very few tumor cells, lots of other maybe say inflammatory cells in the background, I do find it a little difficult. So, but I think minimum of 2 cores is the recommendation. Um, 4 cores, very good. If you have 2 to 4 cores, it's really good if you for ERPR HER2 testing. For gastric biopsies, say around the recommendations are say around 4 tissue cores, 4 tissue bits having tumor should be a good one, but I don't know how many of us are following. Regarding 100 cells that we use for PDL1 testing, 100 or more, sometimes it is difficult to get 100, but if we can confidently call it on the invasive focus, I think I would take a call on that. Yeah. What is your opinion?
Divya, is tumor heterogeneity a bit of an issue for HER2 in breast
Yes.
cancers?
Yes, yes. So that is why I think for this tumor heterogeneity itself, it is good to have at least 4 cores, and you can then assess the heterogeneity when you have 4 cores. You can easily see that. Yeah.
Okay, so
And since we are all doing testing on cores itself, very few of us do upfront testing on surgical specimens. Only in certain situations we do it on surgical specimens. Since our main tumor is the core, so it's good to have 2 to 4 cores to also, look at tumor heterogeneity, of course. And regarding decal tissue, I think none of us like to use decal tissue for HER2 testing. We take off the soft, if that's the only specimen, we'll try to use the soft tissue bit of it, or maybe using EDTA as a decalcifier rather than acid decalcification.
Okay, so what I'm hearing is that we probably need to kind of talk to our interventional radiology colleagues or the surgeons who are going to take these biopsies, that we need more. Well, as pathologists, we're always asking for more tissue, aren't we? But these things, the heterogeneity matters, and we really do need something better. Metastatic bony lesion, best to avoid unless that's the only lesion, and then we'll try to probably decalcify and do the best that we can. Not the most ideal situation. But the latest NCC and sorry, Dr. Sushila. Yeah.
One small thing I want to add regarding the decalcification. So nowadays we are getting the ion exchange resin. So it gives a very good results with IHC. So nowadays, whenever true cut biopsy, of the bone or the trephine biopsy of the bone marrow and all that, we use this ion exchange resin, which is not depleting the nucleic acids. So we are getting very good results with the HER2 as well as for NGS also. I just want to add my.
That's very nice. So what exactly is that, Dr. Sushila? Would you want to kind of, educate all of us?
The things, it is a calcium ion exchange resin. It is a prepared product. I don't know the kind of what is in that. It is a trade secret. The person came and gave us, and we are using it for the past 3-4 years, and it is giving a good this thing. If you want, I can share the company name later.
Yeah, sure. So all of us can maybe benefit and try that out.
Little costly, but it is giving very good results.
Okay, sounds good. So this is the latest NCCN kind of guideline that at least 6 to 8 cores or tissue chips are required for at least for the gastric cancers. So this is something that the endoscopist needs to be kind of told that this is the bare minimum. So minimum of 5 and optimally 6 to 8 biopsy specimens should be tested to account for intertumoral heterogeneity and to provide sufficient tumor specimen for diagnosis and biomarker testing.
So Jay, do you get 5 to 6? That is my question.
No.
We don't get it. That is the issue.
So that's what I'm saying. We need to kind of, talk to our endoscopy colleagues and insist, and maybe the push should come from the treating physicians as well. So that's something that all of us need to get on board and try to get our colleagues to understand.
They tell we are giving 6 or 7 pinches of tissue, but all the things should have tumor, no? Sometimes there will be no tumor. Most of them will be necrosis, but they argue with us, we have given 6 or 7 bits. That is the problem we face.
So I think
that's universal, I guess.
Yes.
I think good quality invasive tumor cells, whether it is in one or today I have reported a breast ERPR HER2. I've done it on a single core because by the time it reached me, the cores were, depleted and they wanted a confirmation. So I think 5 to 6 without not having good quality invasive tumor cells will again is a bit of a problem. But of course, we need to take a call on these things.
Yes.
I think it's a question of kind of just passing on this information, and the way we started for lung tumors, when we were all struggling with that 1 or 2 cores, and now we get adequate cores for NGS and for histopath and PDL1. I guess AstraZeneca also needs to involve, just the way that other companies involved interventional radiologists and respiratory physicians. You need to involve the endoscopies also as part of these programs to just give them this information that this is what is required. Anyway, let's go down to the other questions that we have. So to our medical oncology colleagues, how would you change your practice in terms of HER2 testing and management? And Dr. Suel already discussed this trials today. So let's ask him, how does his practice currently has it changed because of these trials?
So yes, I think now HER2 is not just a prognostic marker, but also a predictive marker, and we know that it has had far-reaching consequences in breast cancer. And HER2 or TDXT has been changing in the realm of not just HER2 positive breast cancer, but now even in HER2 low, and now with Destiny Breast 06, where you have HER2 ultra low tumors, wherein these therapies are now slowly coming into the earlier lines of management rather than later. Very soon, we would probably have TDXT moving to the new adjuvant realm, because you already have TDXT now coming in the earlier first lines in the metastatic settings, even in patients who are HER2 1 plus, or even lesser than that, which is HER2 low or ultra low. So that is one important change that has come about, especially in low and ultra low tumors. Now, with the advent of this pan tumor HER2 new testing, so I would say that it is important to think of HER2 new for all your different gynecological malignancies, lung cancer, bladder cancer, even pancreatic cancer, wherein the patients have exhausted their first line or the approved therapeutic armamentarium. Not just that, it is also important to know, because it is, for example, in colorectal malignancies, having a HER2 new mutation will also have predict a resistance to anti-EGFR therapy. So if I'm not aware of a HER2 new being positive, and I'm treating a patient with an anti-EGFR therapy, I'm doing more harm than good. So therefore, it is always better to have that information, even if I'm planning to treat the patient with any other targeted therapy, for that matter, whether it is anti-EGFR or anti-VEGF. So I think HER2 is now going the tumor agnostic way, and I think it is better to be prepared for it rather than it coming to you as an unpleasant surprise. Finally,
That's
the question that was being discussed earlier regarding the change in the scoring criteria regarding the therapy, I would just like to add that for the older therapy, like the trastuzumab, pertuzumab, lapantinib, it was the HER2 overexpression that was more important, because these therapies really required a great deal of HER2 expression or amplification in the tumor. With TDXT, there is a completely different mechanism of action, where you have the antibody and the drug, which is a cytotoxic payload. And these drugs actually work at even very low HER2 densities. So when the HER2 is even very low, once the antibody drug conjugate complex get internalized, then you have that bystander effect, and even the neighboring cells get destroyed. So very low density of HER2 new expression will also work. And then finally, for the smaller TKIs, your neratinib, tucatinib, which are the now newer anti-HER2 drugs which are coming into the foray now, these drugs are the ones which require the mutations or the amplification, and not the IHC score. So therefore, it is very important to choose your testing very appropriately, the criteria very appropriately, and also the setting in which you're going to be using the anti-HER2 therapy.
that's very interesting. So, Dr. Sindhura, which tumors would you consider for HER2-directed therapy, especially the TDXT outside of the realm of breast cancers? Are we using the TDXT for non-breast cancers as of now?
So yes, in gastric, if HER2 3 plus and post-trastuzumab, pertuzumab, yes, we have used deruxtecan. And apart from that, even in biliary tract cancers, post standard care, standard line of therapies, we have used it, especially in patients with even HER2 mutation. So I understand that the approved indications are primarily for breast and gastric with overexpression, and lung with NSCLC with HER2 mutation. But it's becoming a tumor agnostic approach. As the patient's lines of therapy get exhausted, we try to look at what can be targeted. See, that is what is becoming a routine here. And with the use of NGS upfront in lung as well as colorectal, we are trying to pick up even the HER2 mutations. So that is actually uh, helping us to identify at what line of therapy should we use deruxtecan. So with the use of deruxtecan, the number of patients who can be treated with HER2 directed therapies is increasing. So it's
Wonderful.
primarily overexpression in breast and gastric and other biliary and stuff. But for lung, we are using mutation, and even for colon, we are looking for mutation. Yes.
That's good. Yeah. So what would you perceive
So
as the barriers in?
one clarification I would like to seek from my pathology colleagues and Dr. Jay sir. You're also dealing with a lot of molecular oncology. How is it, as a medical oncologist, do I differentiate a mutation of HER2 as an activating versus a missense or a nonsense mutation? Because only a activating HER2 mutation is what I understand will probably result in a amplification, and therefore the TDXT would be useful versus some mutation which is perhaps not an activating mutation for the HER2 domain.
So that's something that the bioinformatics will take care of it, and they will be. We should be able to find out what are the activating mutations. But mainly, what you do get is HER2 exon 20 insertions or deletions in that domain. Amplifications are again picked up by NGS, so that's something that we should be able to give you that information. These are what my thoughts are. Does anybody have any other thoughts on it, Dr. Sushila, Dr. Divya?
So NGS will pick up amplification as well as mutation. So sometimes it gives confusion whether it is amplification or this thing. And still we are in the learning period only. We have not mastered in NGS and all that. So we just share our information with our medical oncologist, and we both sit together and solve the issue. So if it is a mutation in lung, they go for deruxtecan, and colon also, as Dr. Sindhura told, they start the DXT treatment. If it is only overexpression, only ISC is showing, NGS is not showing anything, then they go for trastuzumab or pertuzumab. That is the practice we in our hospital we are doing. I think I
Okay,
answered your
perfect.
question.
So I don't know whether I would be right in answering this question, but if you look into the Destiny Lung trial, wherein all the patients had HER2 mutation and only few had HER2 amplification in that. So all
Yes,
these patients were looked after at amplification as well as overexpression. But irrespective of whether it was amplified or not, TDXD did work.
yes.
Yeah, I will be coming to addressing that in maybe a couple of slides. So yeah, we'll discuss it there.
Sure.
But since we are at it, Dr. Sindhura, what do you perceive as barriers in identifying patients who have HER2 IHC 3 plus solid tumors? Uh, would any of these be a hindrance, scarcity of tissue, or depending on the stage of the tumor and what line of treatment? And would it be your kind of discomfort with the pathologist not scoring it appropriately?
So, tissue scarcity at least is not an issue in breast and gastric. Most of the patients would have an adequate biopsy specimen, and it is usually done. The primary difficulty comes with biliary tract, wherein to establish a diagnosis itself will be a great difficulty because majority of the samples are breast cytology and ERCP guided samplings. So tissue scarcity is definitely a problem in biliary, but rest of the things and lung as well. And with the increasing use of NGS, we need tissue for NGS, we need tissue for PDL1, we also need tissue for HER2 IHC. At that time, majority of the patients do come with tissue scarcity.
Yeah, biliary tract is a bit of a problem because it doesn't even shed enough to,
Yeah.
kind of deploy the liquid biopsy. So it's always going to remain a challenge. So that's good. So in continuation to that, are there any critical considerations for biopsy? Is a technique, we just discussed that, choosing. Dr. Sindhura, would it matter if you chose a primary tumor site or a metastatic site for evaluation? And we also briefly discussed the ideal number of tissue cores. So maybe you can answer this question. Does it matter if you go for the primary tumor or the metastatic tumor?
We prefer to use the primary tumor where and when possible because again HER2 positive tumor or overexpression tumors are generally heterogeneous. Tumor heterogeneity again plays a role here. So where and when feasible it's a primary tumor, but as a desperate situation, sometimes if a patient progresses and we are opting for a second biopsy, it's okay to use a metastatic site.
Okay, that's interesting. I'm just going to share some of this data with you. Is that some of it even I wasn't very aware of, but this study had some 108 tumors, and 10 of it, so about 10% of them, there was a negative conversion. The primary site actually showed a score 3, and this study actually did paired samples at the same time. So basically, to disprove the hypothesis that it's pre-analytic factor which is causing something to be negative, so they paired the samples, primary and the synchronous metastatic sites, with the same surgical procedure and the same pre-analytic technology or the methodology. And what they said was 10 of those 108 cases, something which was positive in the primary site, completely negative at the metastatic site, and vice versa, something which was negative in the primary site became positive. So testing HER2 expression only, for example, and this is in the primary in gastric cancers, may actually exclude from the targeted treatment a percentage of patients with a HER2 negative primary tumor, but a HER2 positive metastasis. So time may come when that you might have to get a paired sample from both. And this GASTA study actually showed the dynamic nature of HER2 expression. This is, of course, post therapy. Sometimes when the initial biopsy was negative, the repeat turned out to be positive, or the metastatic site turned out to be positive. So repeat HER2 assessment in primary and metastatic or recurrent sites is actually recommended when the patients have advanced disease and when the initial tumor was HER2 negative. And the GASTR3 actually investigated whether HER2 expression in patients with HER2 positive gastric cancer, does it get affected by the first-line trastuzumab-based therapy? And the answer is yes, actually. They suggested the HER2 loss. Sometimes it happens as a mechanism of acquired resistance to these trastuzumab-based therapies. And patients who exhibit HER2 loss may also have a poor response to second-line trastuzumab-based therapy and a worse PFS versus patients with a persistent HER2 positivity. So it works both ways. But the bottom line here is that, therefore, reassessment of HER2 status is recommended, feasible to obtain a new tumor specimen, obviously, in patients with a HER2 positive gastric cancer after prior trastuzumab-based therapy and before initiating a new anti-HER2 treatment such as TDXT. So these slides actually tell you that one should escalate a reflex, something which you are expecting to be HER2 positive, or at least if it's negative, to actually try the metastatic site as well. And if it's a treated case, you would still want to test the fresh specimen to see if there is HER2 expression which is lost or is still retained, because that's going to give you some additional information about what next line of therapy to use. Now, this is what we are discussing about NSCLC HER2 expression versus HER2 amplification. So in this study in 2019 of Japanese patients with metastatic NSCLC, the frequency of HER2 alterations was evaluated. 3% showed IHC 3 plus or 2 plus, that's amplification. And of these, about 2.9, again 3%, showed HER2 mutations, but there was no overlap identified between these tumors. So the mutations were different than the HER2 IHC. Also, patients who had IHC score 3 did not necessarily show amplification. So there was some mechanism different than amplification, which was leading to a protein overexpression. So in this scenario, basically to our treating colleagues, when would you consider TDXT in lung cancers? When there is an IHC score 3? If there is an activating mutation, which we discuss, yes, we always do that, or if there's an ERB2 amplification. So essentially, the question here is, would you deploy TDXT if there is IHC score 3? Dr. Suhail, would you want to answer that?
So in lung, where I'm actually looking at involvement of TDXT and perhaps later line of therapy, my stress would be on detecting an activating mutation, a canonical HER2 mutation that would enable me to give TDXT. And I think most of the panels in NGS for lung cancer that we do upfront do include ERBB2 mutations as part of the routine testing armamentarium. So another important thing that I would consider in the question that was asked previously, where you were discussing about the spatial heterogeneity of HER2 with respect to the primary or the metastatic site, or the temporal heterogeneity with respect to HER2 getting lost or HER2 getting acquired as a result of clonal evolution, I would say that one important thing that we all must take into account is the role of liquid biopsy. And many of the times, the liquid biopsy becomes a very important tool in or even those tumors which are not, routinely being tested for HER2, and you might be able to take them as candidates for targeted therapy if we're able to detect that on the ctDNA.
Okay, and considering that the tissue is very limited for lung tumors, how would you recommend triaging these biomarkers? Would you want some IHC beforehand or NGS? But I guess this question is redundant now because we do get enough tissue for lung tumors, and everybody kind of triages it. I mean, it's the pathologist's prerogative to triage this thing to preserve the tissue for further biomarker testing. So I'm going to skip this, but
So
something
as
which
far as
is
lung is concerned, I think I'm happy doing a liquid biopsy as well upfront. And I think that is going to solve the
no, Dr.
issue if
So
the
we're
tissue is a problem.
talking of overexpression. So that's not going to be possible by liquid biopsy.
Correct.
We're talking of protein
Correct.
overexpression. And the reason
Correct.
I'm kind of spending some time on this is the latest, this is the NCCN guideline version 7 of 2025 actually says that, and this is highlighted here, is that the need for evaluation of HER2 protein overexpression, and is something which I personally was also not aware of at all. This is in the NCCN guideline now, is that you should check for HER2 overexpression, and which is defined as 3+ tumor cell staining based on IHC. There is no current recommendation regarding the specific IHC antibody clone, so they don't actually put down whether it's a DARPO Herceptin or the 4B5 or Ventana. And the scoring criteria recommendation is to still use the gastric criteria. So this is something which is quite new, and this is in the latest guidelines along with CMET IHC that they recommend, the NCCN, and the HER2 IHC is also one of the things. So that's something I'm not sure if all the medical oncologists knew, at least I wasn't aware of it. It's quite recent, and we all need to remember now that we might be called upon to investigate for HER2 protein overexpression in lung tumors. I guess the block which we have triage for PDL1 might get kind of used up here, or for the CMET IHC to evaluate this. So this is something which I thought was worth sharing with all of us. And coming to the fag end of this kind of very interesting discussion, is that two of my pathology colleagues, how do you resolve ambiguous results of 2+ in gastric cancers? Do you do HER2 FISH or a KISH? Or would you want to repeat it on the Ventana platform, as Dr. Sushila said, if it was not already done on Ventana? So, Dr. Divya, what do you feel?
If it was not done on the Ventana platform, then confirm it on the Ventana platform. But otherwise, we do the Ventana platform. So HER2 2+ is confirmed by FISH at our
Dr.
center.
Sushila, is it, I mean, interpretation of this HER2-ish or FISH, is it difficult vis-a-vis breast cancer because there's so much heterogeneity? How do you actually co-localize the signals in those particular same cancer cell cluster? I myself don't do FISH, honest to goodness, so I really wouldn't know, but I wanted to hear from either Dr. Divya or Sushila. I mean, if they do that, is it easy? Is it difficult? How does it pan
In
out?
breast, it is comfortable. We can comfortably report in.
Absolutely.
But in gastric cancers, we have to mark the area where the tumor cell is located and all that. Little difficult. If it is nicely positive, means it is easy to report. I mean, when the FISH is nicely worked and we are seeing signals nicely, means confidently we can report. Otherwise, we are not that much confident in reporting 2+. So in such cases, we go for repeat biopsy and reflex testing.
Okay, fair enough. Dr. Divya, do you have any different thoughts on this? Do you do FISH for this gastric cancers or KISH or anything, whichever is applicable?
So I personally don't do it. My colleagues in cytogenetics do, but I believe that they face issues. Again, the issues faced in IHC are issues faced in FISH in gastric cancer because of tumor heterogeneity.
Yes.
Absolutely. So this is
I
what we want to
believe-
kind of bring to the point here, is that it's not easy to do evaluation of this gastric cancer score twos. Nobody can really swear and say that, that's 100% unless you're able to co-localize that cancer cell cluster very clearly on the deeper section of that tissue. So that's one of the inherent problems. That's the biology of the disease, and we do face problems with that. From there, I think this is the end of the thing. So the key takeaways are that clinical guidelines recommend HER2 IHC testing across solid tumor types. That's beyond breast and gastric cancers. This has been equally highlighted by me in this talk and the prior talk by Dr. Suhail. HER2 positivity by IHC should be separately assessed regardless of NGS results for HER2 amplification or mutation, because protein overexpression matters even, say, for lung. The ASCO-CAP gastric guidelines and scoring criteria may be applied to certain solid tumor types in addition to the gastric solid tumors. We all agreed upon that. And CAP's updated gynac biomarker testing templates includes HER2 scoring criteria for endometrial, cervical, and ovarian cancers. Essentially, it recommends to use the gastric tumor criteria. So almost everything outside of the breast and maybe the salivary glands will have the gastric criteria. I think that's all that I have. I think we are open for discussion. We possibly have, I think, 5 more minutes to discuss. If there are queries, I don't know if there are queries in the box, Dr. Vivek.
Yeah, there are a couple of questions. Let me go through them one by one. So, has TDX been tried in HER2 negative colorectal cancers? So maybe Dr. Sohail, would you like to answer this question?
So not HER2 negative, but yes, for patients who have some kind of HER2 expression in terms of HER2 new amplification or HER2 new IHC positivity, in those patients, yes. And even the HER2 pan tumor would ideally want you to have either HER2 IHC 3 plus or 2 plus with FISH positivity or an NGS positivity. For negative colorectal carcinoma, no, to the best of my knowledge. No.
Yeah. So the next question is like for the pathologist, it is ISC 2 plus. Can we use D-dish testing, which is a dual color, dual hapten C2 hybridization testing? It's yeah.
Yes, one can use that, definitely. I mean, it's either FISH or this KISH.
Yes.
Okay. Perfect. So, and the next question is to the oncologist. He is specifically marked to the oncologist. Whether you consider the new HER2 positive, HER2 breast scoring of HER2 low or ultra low, if it is not done in Ventana platform using 4B5 clone. In some lab reports that using platform other than Ventana, do you want to read? I think this is already answered by, yeah, it's well answered already. And the last question which I see is the routine histomorphological good with ion exchange resin for bone biopsy? As we get bone biopsy, we don't know that MATS is present or not in the time of taking the biopsy. No.
Again, it was answered by Dr. Sushila. I think she gave a comment on that.
Yeah, just one more quick question, although it was a very extensive and a very informative panel discussion. What is the like borderline tumors? Do we go for HER2 if they're positive for HER2 ISC, HER2 3 plus? So what do we do for those kind of borderline tumors, specifically in ovary or like means any answers for that? Just I came.
No idea.
It's not mentioned in the trials or anything, but I just came across few of the borderline cases in ovarian carcinoma that were ISC 3 plus. And we just started this HER2 testing in the ovarian
In
cancers.
breast, if it is DCIS, we don't take it into account. So
Okay.
considering DCIS is equal to borderline means we should not consider. It is only hypothesis. It is not any guideline. But in
Yeah,
DCIS breast, we don't, if it is 3 plus also, we don't consider it as HER2 plus. Only invasion we are taking into account. So even in borderline, we should consider the same. I don't think, but nothing has been given as guidelines. I'm simply telling.
Not mentioned, so I just came out of curiosity, like to, yeah.
Okay, I have one last thing. There was one slide which I missed out where it asked what do the pathologists expect from the medical oncologist in terms of giving the clinical details? And there was another question for the medical oncologist, what do you expect from us pathologists on the report? So should we first ask our guests, Dr. Suhail and Dr. Sindhura, one by one, what do you expect from the pathologists on the HER2 report? I'll stick to the HER2, otherwise there'll be a litany of complaints.
No. I think the role of a pathologist continues to evolve along with any new drug that comes with a companion diagnostic, and it's not easy days for them as well. So I think it's hats off to all the pathologists who do their bit in helping us reach conclusion to interpret the IHC reports or the NGS reports or the FISH reports for that matter. I think there is a curve, Dr. Jay sir, which we all climb together hand in hand, and I think that curve we climbed when the FISH testing was introduced and the CAP guidelines later on came into vogue and it became universal. And when the guidelines kind of differentiated as per the TOGA trial for the gastric, and now we are climbing that curve again for the HER2 low and the ultra low. So I think we are both learning together. I would assume that it's a by-way process. You also teach us how you interpret the HER2 low and the ultra low, because if we are to extend the benefit of these therapies to those patients on the borderline who are less than 10% membrane staining and the HER2 low and the ultra low, and that a lot of subjectivity comes into play in those areas. I think that is where we need to collaborate more. And now I think with the advent of artificial intelligence in pathology and in medical oncology, I think we all need to learn how best utilize AI as a friend rather than an enemy.
That's very nice. I think all pathologists are going to love Dr. Suhail after what he said, So, no, I mean, I guess, it's the talking, if you interact more with the treating physicians, your colleagues, you're going to learn more and help. Dr. Sindhula, do you echo Dr. Suhail's thoughts? Do you have anything else to add for us?
Definitely. And one more thing. So the percentage of tumor cells which are actually positive for HER2 new, I think also adds up to some information. So recently came across one case of carcinoma breast. Initially was hormone positive. At recurrence, she was HER2 new 3+. She never responded to any form of HER2 new therapy so far because of financial concerns. We recently had started on trastuzumab deruxtecan TDXD. So on repeatedly looking at the HER2 new evaluation on the baseline or the archival tissue of the metastatic site, it's 3+, but the percentage positivity is less and the patient never responded to this therapy. So such things probably could be of value. That's the only thing maybe of clinical importance to us. And rest, I echo with what Dr. Suhail has said. It was
Okay.
very nice listening to him.
No, point taken. I mean, I think with the advent of the HER2 low and ultra low, I think most pathologists have started writing about the actual raw data of how we actually evaluate. So what's the intensity in how many percent cells? And I think going forward, that will become a habitual thing for everybody to write. Dr. Sushila, Dr. Divya, do you have any
Yes.
requests from your treating colleagues? What should they be, providing you all the time?
More tissue.
More tissue.
Lots
More
of
tissue,
tissue.
yeah, that is the thing. And
Lots of
another thing,
tissue.
no complaints. Whenever we ask for more tissue, they should not complain, and they should
Yeah,
understand why we are asking for, because there are so many tests you are asking us to do. First, you ask NGS. For example, in lung tissue, you ask for NGS first. When the NGS QC fail, when we tell that QC failed, madam, shall we go ahead with some other thing? Then we have to divide the tissue for EGFR by PCR, ALK by IHC, and ROS by FISH, and PDL1 also you will ask. So in such cases, we need more tissue. So we ask for repeat biopsy. Then you get angry with this. Please don't get
so
angry.
I won't name somebody, but when I was back in Tata Hospital in one of the MDTs, I was told that, in frustration by one of the doctors that you guys should only be happy with a post-mortem specimen. How much more are we going to get and give you? But
Yes,
point
you are
taken,
greedy.
the medical oncologists are sitting across the table from a patient who has exhausted
Yes,
all kinds of, things, and
yes,
they want to try out. But I guess it's again, as Dr. Soel said, it's bi-directional. You talk, you explain the need for something, and it has to be
yes,
taken in the right spirit. You have to go out of the way to accommodate that request. It's just not for the sake of asking, but it does have material difference
yes.
in actually treating. So I think what we say is, I think we are all happy with each other, and we
Yes,
should just
and
talk.
we used to add the viable tumor quantity in the histopathology report itself, so that the medical oncologist will have an idea what to ask for. So if it is only 5%, 10%, then he will ask only EGFR by PCR. First, you tell me that, Sushila. After that, we will plan any repeat
Perfect.
biopsy.
Yeah, whatever works. Maybe that's the MDT protocol, or something which you kind of actually deliver on the report or something. Yeah, whatever works best for the patient, I think should be accommodated.
Yes.
So
Sorry,
we
I
For
also
took
the
a bit
add
medical
of time.
we
oncologist,
also
for
add
the
Dr.
medical
Divya
viable
has
tumor
something to
oncologist,
cells.
say.
So it's nice to add viable tumor cells. We also add amount of necrosis also. So we say 30% tumor cellularity, 20% necrosis. This information, I think, also will help them to understand if QC fails.
Yes, correct.
So I think, sir, for both medical oncologists as well as pathologists, let us not forget that the intervention radiologist should also be our good friend, and we should keep him in our good books and keep him in good humor so that he gives us adequate tissue. And as they say in Urdu, there is a couplet: which goes like चमन में इख्तिलात और रंगो बू से बात बनती है. चमन is a garden and इख्तिलात और रंगो बू means amalgamation of fragrance and color. तो चमन में इख्तिलात और रंगो बू से बात बनती है. तुम ही तुम हो तो क्या तुम हो, हम ही हम हैं तो क्या हम हैं.
Papa.
So, Shrikant, you need to get interventional radiologists and endoscopists to sit on one of these meetings, because we need to disseminate that information to them as well.
Absolutely, sir. Thanks for bringing up this point. Going forward, we'll make a note and we'll see how we can include them in this MDT, and we'll also make a note and how we can do some educational activities around, especially the sample acquisition, how it is important, and even they're like very crucial. Once the biopsy or sample acquisition is done, the cold ischemia time, the transition period is very crucial. We have something in mind, sir. Maybe experts like you, we need a guidance from all you people. Once we formalize the plan, we will come to you with all your inputs. We will try to implement all this plan, what we are going to make it up. And thanks for all the panelists for bringing up this point.
And a wonderful set of panelists. Thank you so much for being active participants in this thing. Dr. Vivek, back to you.
Thank you.
Dr. Jay, and thank you all the panel members for this wonderful discussion. We are about to conclude this webinar. Just before concluding, I'd like to put away a little bit takeaways for the audience. A couple of points like HER2, like number one is HER2 is not limited to breast cancer and gastric cancer, but it is relevant across the multiple solid tumors. And there has been establishing HER2 as a pan-tumor biomarker in precision oncology. Then HER2 scoring, we can take it beyond breast and gastric cancer, but it's inconsistent and there's a need for clinical validated diagnostic tests and consistent algorithm to score HER2 tumors beyond the breast cancers and the gastric cancers. But yes, the certain studies have used the guidelines, ASCO and CAP gastric guidelines for scoring criteria may be applied to certain solid tumors and which were used in the clinical trials as elaborated. And early and the appropriate HER2 testing is essential to identify patients who can benefit from novel ADCs. And with this, let's try to carry forward today's learning to our clinical and diagnostic practice and continue to collaborate for better patient outcome. And this is the key takeaways. And I would like to propose a vote of thanks to, I'd like to thank Molecular Pathology Association of India for providing this opportunity. And my sincere thanks to the distinguished faculty members, Dr. Sohail, Dr. Jay, Dr. Divya, Dr. Sushila, and Dr. Sindhura for accepting this invite and taking part in the educational event and disseminating the knowledge of HER2 scoring, interpretation, treatment implication in solid tumors beyond breast and gastric cancer. We had a good and engaging session today. I thank to the organizing body, MPA and IAIO, and acknowledge the support of AstraZeneca. And thanks for the audience for active participation. There's another announcement, like we are continuing with the series of this webinar, and we are holding another webinar from on 25th of September on the topic of test failure in next generation sequencing, unraveling the root cause to minimize the failure. And so please stay connected for the audience and for every one of us to stay connected to be updated about the next seminars and with the kind of support us in the continuing this webinar of MPIs. Thank you.
Thank you.
Thank you, everyone.
Thank you.
Thanks,
Good night.
everyone. Thank you.
Thank you.
Jay, bye.